Okay, everyone. So today we will have our last class of immunology. We will be having only one more class after this regarding immunology, in which we will review the whole system. So today we are going to speak about transplant and transplant rejection. And after we finish that, we'll speak about different immunosuppressant drug, and we will speak about monoclonal antibodies. So this is our task for today. If we'll have some time, we'll try to finish something else, but mainly I want to finish these 4 pages with you today. Before I start with this, there is some good information and some good news that I have for you. I don't know if you noticed what I have sent on the group, but basically what happened that in the US there is going to be 2,000 new seats for residency, which means that your chance of matching is much higher now. So right now for this year the matching rate is going to be 51%. So if 10 of you apply this year, only 5 of them will match, 5 of them will not match. But from the next year the matching rate is going to go up to 75%, which means that from every 10 of you guys, 7.5, almost 7 to 8 people of you are going to match, which is an amazing news. If you do have a US like citizenship, this is a plus for you. That makes the process easier. If you have like a research, that brings a plus. If you like doing some form of elective in the US, some hometown electives, all of these could be a plus for you. And if you need any question regarding this stuff, please contact me and we can figure out something together. So for today, we are going to speak about the transplant rejection. By the way, for the question I sent, the answer is TAP, but you guys will try to solve it all day long. It's a really difficult question, and tomorrow I will be releasing the way how I answered it, but the last answer will be TAP, but you need to know how it happened. So for someone who gets a transplant rejection, there is many ways of getting a transplant rejection. We have hyperacute, acute, chronic, and graft versus host. These 3 forms about TAB protein, you can find it like I sent a couple of photos about it when I was explaining this. If you remember when I was explaining this, I sent a couple of photos in the group. I can send it to you, and in addition today I will send you an article about the TAB protein. Actually, I was surprised that they asked a question about it, since it's like not typical for them to ask a question about something between the lines. That's why I shared the question with you guys. I will be sharing more questions soon, but only on this group, because these form of a question are kind of sensitive and would not like to share them anywhere else. It will be only in our group. So the transplant rejection. Hyperacute. So what is the story here? You give the patient the new organ. The moment you put the organ inside of the patient, you put the blood supply, and boom, the tissue is dead. How can you tell that the tissue has died? Basically, you will have widespread thrombosis. The whole tissue will have so many clots inside of it, and it's kind of scary because that patient that was waiting for that organ for so long has lost it in a second. Okay, so it's kind of messed up, and when you look at the organ, it will be motile. It will be pale. It will be sometimes have thrombosis inside of it, and basically it means that the organ is totally dysfunctional. Look what happened in it. So many thrombi inside of it. And the moment you see that, and it happens immediately, within seconds, guys. And if this happens, what you can do with this organ? What should you do with this organ now? You are doing a transplant. You just this patient was waiting for this organ for 10 years. And finally, he got the organ. You put the organ inside of him, and this happened. Really quick, there was a thrombosis all over the organ. What can you do about this organ? What do you think will help? It's hyperacute, so you must remove it. It doesn't matter, because if you keep it, it will kill the patient. So you must remove it. Okay? So, yep. So the transplant rejection happens within minutes, and the pathogenesis goes something like this. A pre-existing recipient antibodies reacts to the donor antigen. Well, you gave a new kidney to the patient, yes? But that patient has so many preformed antibodies inside of his body against some of the MHCs of the kidney, yeah? Well, the transplanted kidney. So this is the host, yeah? This is the host with the antibodies, and this is the donor. Now I have a question, guys. Do you remember what codes for the MHC? I mean, which gene codes for the MHC? The major histocompatibility. Excellent. It's the HLA, the human leukocyte antigen. So the HLA codes for the MHCs. So before you even give a transplant to the patient, to avoid such form of a rejection, you need to check the HLA for this patient, okay? And this process of checking the HLA, there is different ways to do it, but basically you need to check that this patient do have the exact same HLA as the donor, the same as the patient. And let me send you a picture how this looks like. So basically, when you take a look here, you have a patient here. He's 10 out of 10. This is amazing. That means that he has really low risk of rejection, okay? While this donor have 9 out of 10. Will we donate this kidney? Guys, will we donate this kidney? 9 out of 10. Yes, we'll still donate it. That's true. We still donate it. Yes, there is a chance of rejection, but it's not high. With some anti-immune system medication, it can be like good enough, you know? So we'll suppress his immune system in a way that will prevent the rejection, basically, okay? So you must, if you get a question, what you need to check before a transplant, the answer is HLA, human leukocyte antigen. Why? Because it codes for the MHC. Good. So let's take a look at about the next thing. Oh no, not this. So the next thing you must know about, what is this? Oh yeah, this one. Okay, so it happens within minutes. A pre-existing recipient or the host antibodies react to the donor antigen. It's a type 2 hypersensitivity reaction. Remember, guys, about when we spoke about type 2 hypersensitivity reaction, we said that the mediator of them was what? Antibodies, okay? It activates the complement, and the complement will destroy this new organ. You need to know the features. So you will have a widespread thrombosis of the graft vessels. So if you can see, this is a kidney, this is a glomerulus, and inside of the glomerulus, there is a lot of blood here, blood here. There's basically thrombosis inside of the glomerulus. So it can be also ischemia and fibrinoid necrosis, and the graft must be removed. Let's take a look at the hyperacute transplant rejection. Histology, of course. So, as you can see, the vessel is full with the blood. This is a thrombus, basically. And this thrombus has occurred inside of the newly transplanted kidney. And it occurs within minutes. Yep, occurs within minutes. Super important. Yep. So, as you can see, again, here we have anti-HLA antibody. These are in the recipient. This is the donor HLA, and they connect to each other, complement what the classical pathway gets activated, membrane attack complex get formed, and then you will have some destruction here, which lead to release of von Willebrand factor and then thrombosis. Okay? So, again, the recipient has anti-HLA. Donor has HLA antigen, and these two hate each other. So, they bind to each other. Next, activation of what? The classical pathway of the complement. And the start, of course, with the C1. Formation of membrane attack complex, release of von Willebrand factor, eventually leading to thrombosis. I hope you understand that. Okay, so that's it for that one. I hope you understood it. The hyperacute organ transplant. Main idea is to remember that there will be a lot of clots formation inside of these organs. Yeah? And for the next one, oh yeah, you can see. Yeah, this one. If you take a look at this one, you can see all of this thrombosis inside of it. Yeah? Okay, good. So the next one is about the acute form of a transplant rejection. Please hold your pen and write a note. Here, less than 6 months. Here, more than 6 months. So why this is helpful? Because the moment you look at the question and they tell you a patient got a kidney donation, a patient got a kidney transplant 7 months ago, you say something like this. Okay, it's not acute. Done. A patient got a kidney transplant 4 months ago. So you close your eye and be like, okay, it's not what? It's not chronic. So it's all about the timing. Less than 6 months, acute. More than 6 months, chronic. So the acute one happens between weeks to months, to make it simple, less than 6 weeks. And it has both cellular and humoral immunity. So speaking about the cellular form of immunity, it's a CD8 T cells and or CD4 T cells activated against donor MHC. So the donor gave you a kidney. He has an MHC that are a little bit different. Yeah? In the first case, there was like significantly different, like it was 2 out of 10. Yes? In this patient, it could be like something like 6 out of 10. And yeah, basically you start to form antibody against them. And now you have formed antibody, which takes time to form. Or it can be an actual CD8 T cell destruction. Guys, please make a note. Mostly in acute, the immune reaction is not a CD4, but it is a CD8. So mostly it will be a CD8 T cell response, okay? Rarely it can be CD4. So a humoral one, similar to hyperacute, except antibody develop after the transplant because they need time to form. It's associated with the C4D deposition. Please make a huge note again that the main form of pathogenesis for the acute transplant rejection is the CD8 T cells. And for the chronic, it will be the CD4. But for now, I want you to know it's the CD8 for this one. Okay. So what will this patient have? The first patient had this thrombosis of the tissue. What about this patient? He will have vasculitis with lymphocyte infiltration, okay? Vasculitis of the graft vessels with dense interstitial lymphocytic infiltrate. Maybe you find it weird I'm not looking at the picture here because simply I don't like them. They are bad quality and it's difficult to see exactly what is happening there. While if you take a look at this one, if you take a look at this one, yep, there is plenty of nuclei inside of this picture, like ridiculous amount of nuclei. What does these nuclei represent, guys? Does anybody know what does these nuclei represent? What does this nuclei represent? It's an acute transplant rejection. So actually, these nuclei represent a lot of lymphocyte. So you can see a lot of lymphocytic infiltrate between the tubules. So let's try to take a look at a deeper look at this picture. First of all, this is a kidney, okay? And you can see here tubules, okay? What else you can see here? Yep, tubules, tubules, tubules. You can see plenty of what? These cells. Can you see? Cell, plenty of cells. What are these? These are lymphocytes, okay? And these lymphocytes are infiltrating the tissue, so that means it's an acute rejection, okay? It's an acute rejection. Okay. So, yeah. They write there will be vasculitis of a graft vessels with dense interstitial lymphocytic infiltrate. So as you can see in this really bad picture, there is a lot. These are the what? These are the tubules, tubules, tubules. One more. And between them, you can see a lot of what? Inflammatory cells. So you can see monocytes all over the place. So this is highly characteristic of acute rejection. Okay, how can you prevent it? Megadose of steroids. You give methylprednisone. Search for this answer in your exam. Methylprednisone. Okay, methylprednisone. So this is the immunosuppressant you give it, and you give it in a way of bolus, which means it's one big injection to the patient. Okay, done with hyperacute and acute. Let's speak about chronic. For the chronic one, I want you to know, again, they say, oh, it's the same as acute and all of that. Time is gold, guys. So this one is less than 6 months, while this one is more than 6 months. Done. So for the chronic one, as we said, it's more than 6 months. The CD4 T cells respond to the recipient antigen presenting cells presenting donor peptide. Let's speak about that. So we have the T cell CD4 cells, okay? The recipient cells now, antigen presenting cells. Now the organ, let's say it was the kidney, has been inside of the body for a long time. So a little bit of antigen will be taken to the antigen presented cells, and it will be presented on the MHC, yes? So after it will be presented on the MHC, the CD4 will be responding to it, yes? Because she must. So when she take a look at this antigen, she will be like, okay, I see what is the problem. So you want me, the CD4, to kill that antigen that you just showed me, antigen presenting cell, correct? I'd be like, yes, and be like, okay, let me do this for you. So how does CD4 kills? It activates the Th1 and the Th2, which activate both the cellular and the humoral component, which means type 2 and type 4 hypersensitivity reaction. Let me re-explain this, but on a different page. I want to re-explain it on this page that is really difficult to get the grab of. So, what happens exactly? In case of chronic, guys, when it happens, can you give me a timeline? More than 6 months or less than 6 months? Excellent. It's more than 6 months. So after 6 months, what will happen? You have your CD4, okay? CD4 cells, and you also have your antigen presenting cells. This antigen presenting cells will basically recognize that the new kidney, the donated kidney, is not from their region, you know, it's foreigner. So it sees that and be like, oh, well, this is not for us. So she decides she want to kill him. Well, how she want to kill him? She will take a piece of him, okay? After taking this piece, it will take the piece and basically put it on the MHC that she has. So she will take that piece, and after taking that piece, she will put it right here. And after that, the CD4 will be like, cool, okay, so I see this foreigner piece and you are requesting me to kill it? She's like, yes. So he'd be like, okay, let me do that. So the CD4, here it is. The CD4 T cells go and convert to the T helper cells, which activate the T helper 1 cells, leading to cellular response, and T helper 2 cells, leading to humoral response or antibody response. And both of these will kill the kidney. Okay? I hope it makes sense. No, come here. Okay. Done. So we go to the next thing. Yep. So recipient T cells react and secrete cytokines, leading to proliferation of the vascular smooth muscle. You're like, well, that doesn't sound that bad. It's just smooth muscles proliferation. Well, parenchymal atrophy will occur and then interstitial fibrosis. Guys, is fibrosis reversible? Is fibrosis reversible? It's not. Yep, it's not. So if fibrosis occur, it's basically the tissue, it's better to throw it away and bring a new one. So it will be dominated by arteriosclerosis. Wow, well, arteriosclerosis, I miss that person. Guys, do you remember when we spoke about arteriosclerosis? First of all, do you remember which system it was? Was it in renal or CVS? Yep, in the heart. And do you remember that we had affection of which size vessel in it? The middle and the small size vessel. Excellent. And do you remember when we spoke about this disease, the arteriosclerosis, we said it had two types, the Mockingbird, and the other one was the arteriolosclerosis, yeah? So the Mockingbird, can somebody tell me regarding the Mockingbird, what is the percentage in occlusion in it? How much it was? In Mockingbird arteriosclerosis. How much occlusion did you have of the vessel? In Mockingbird, there was no occlusion of the vessel. Remember, in Mockingbird sclerosis, you had calcification of the tunica media, not tunica intima, which means that you had a lot of calcium in the walls. As you can see, calcium is bluish, yeah? Well, the lumen itself is not occluded. So in the Mockingbird, you have basically no occlusion of the lumen. The occlusion of the lumen is 0. That was a tricky question. Sorry guys, I like to do that. So, yep, basically the walls will be calcified, but the inside will have normal passage of blood. Why do we study it? Because if you see something like this on an X-ray, you need to say, oh, it's normal, okay? And some other condition regarding breast cancer, because it can mimic breast cancer when the patient actually does not have cancer. So, moving back here, we have the following. Organ-specific examples include chronic allographic nephropathy. So if you take a kidney and you transplant it from a person to a person, after 6 months, there is a chance of chronic rejection. So if that rejection happened, we call it chronic allographic nephropathy. If you're looking at histology, you will see arteriosclerosis. Remember, when we spoke about the other type, which was the arteriolosclerosis, it has two subtypes, the hyaline and the hyperplastic, yeah? So, Other form is bronchiolitis obliterans, which happens in lung transplantation. I want you to make a note near it. In case of a bronchiolitis obliterans, there will be wheezing over the lung. Wheezing over the lung. The next condition is accelerated atherosclerosis. So if you change a heart of the patient, they can get atherosclerosis really quick. Also, vanishing bile duct syndrome. In vanishing bile duct syndrome, it happens after liver transplantation. So vanishing bile duct syndrome. So after the liver transplantation, they can have loss of the bile ducts. They have loss of the bile ducts, they can get biliary cirrhosis. And when they get the biliary cirrhosis, look at this freaking liver. It's so yellow, yeah? Yep. And the bronchiolitis obliterans. Let's take a look at the, and guys, I really want you to know about the idea of wheezing. So what is wheezing? If I get a tube and I blow in it, it will be like, but if I make the tube much more narrower, it will start to whistle. It will be like, so that's what happens due to the obliteration of the bronchi. They become smaller. So when they become smaller, there is more chance of making the sound. Yeah? So let me send this. Okay, so moving on, we have the next one, graft versus host. Now, the only difference about this one, in the hyperacute, acute, and chronic, who was rejecting whom? Was it the donor rejecting the recipient or the recipient rejecting the donor? Who was rejecting the other one? I really forgot what I said. So was it the donor rejecting the recipient or the recipient rejecting the donor? Now I remember. It's basically the recipient rejecting the donor. Yeah, the recipient, the one who got the kidney, is rejecting the kidney that came to him. Yeah. So basically, this person A and person B. And the person B is getting a new kidney, yeah, from person A. So person B is refusing person A kidney. That is happen in case of hyperacute, acute, and chronic. Now, graft versus host is vice versa. Now, let's say that person A gave person B a liver. So this is person A liver, but we put it in person B. Now this liver be like, I don't like this body. I deserve a better place. So he will reject the body. The liver will reject the body that gave him refuge. So graft versus host disease. The time doesn't matter. The time here matters a lot. So here it was minutes. Here it was less than 6 months. Here it was more than 6 months. While in graft versus host, the time does not matter. I will tell you what matters, by the way. So grafted immune-competent T cells proliferate in the immunocompromised host and reject the host cells with foreign proteins, leading to severe organ dysfunction. Let me explain what happens. If you transplant an organ that contains T cell inside of it, which organs contain T cell inside of them and we do transplant them? Give me examples, please. Which organs can have, yes, bone marrow is one. Bone marrow is one. Completely correct. Bone marrow do have basically T cells inside of it. What else? What else has lymphocyte inside of it and we transplant it? The liver. I just gave it to you guys. So the liver. So when you gave these to this person, they do have T cells inside of them. Yeah, the bone marrow, the liver, they have T cells. So these T cells will start to try to kill whom? The recipient. Okay? Yep. So grafted immunocompetent T cells proliferate in the immunocompromised host. This poor man is immunocompromised. Why? Because you made him immunocompromised. And there is a rejection of the host, rejection of him with foreign proteins. So be like, well, he's foreign to us. Well, you guys are foreign. And that leads to severe organ dysfunction. It's a type 4 hypersensitivity reaction, okay? You must know. So these guys are just to research. They came to the different body that they are, it's not theirs, and it led to huge destruction of the body. Is it always a bad thing? This is a tricky question. Is it always a bad thing? No, it's not. It's not always a bad thing. We will see why in a moment. For now, I want you to know it's a type 4 hypersensitivity reaction. Why? Because it's T cell mediated, okay? It's T cell mediated. Really quick, this was antibody mediated. Hyperacute, antibody mediated. Acute, mostly CD8. Chronic, mostly CD4. Graft versus host, mostly type 4 hypersensitivity reaction mediated by the T cells. So, the symptoms include maculopapular rash, jaundice, diarrhea, hepatosplenomegaly. Basically, a lot of systemic findings. Yes? So when you hear this word systemic finding, you're like, well, damn it, it sounds like serious. It looks like it's going to kill him. And you are completely correct. It can kill the patient. So how come I'm saying that it could be a really good thing? Well, in some patient, exactly. So in some patient who have basically bone marrow transplant, for which case do we do bone marrow transplant? Many cases, including some form of leukemias. Yeah? So, exactly, leukemias. So these patients who have leukemias, when we give them these foreigner T cells, when they enter the body, they found leukemia cells, and they're like, okay, let's kill those first of all, so they can kill the leukemia cell. Anyway, they can lead to huge destruction of your body, leading to maculopapular rash, jaundice as well, because they destroy your RBCs. They can lead to diarrhea because they destroy your intestinal epithelium. They also can lead to hepatosplenomegaly, and usually in the bone marrow and the liver transplant. Why? Because they have a lot of lymphocyte inside of these organs. Potentially beneficial, in which cases, bone marrow transplant for leukemia. So we call it the graft versus host effect. So keep in mind, it's beneficial. Why? Because it's able to kill the leukemia cells. So the T cells from the donor come to the recipient and see what? They see the leukemia cell and they are like, so let me kill you. Okay, now let me kill the body. So in the beginning, they are actually good. They help the patient. In case of leukemia only, do not confuse it and be like, no, Yat said this graft versus host is amazing for the patient. It's not. It's only in that case. Okay? So the next thing, for patients who are immunocompromised, irradiate the blood product prior to transfusion to prevent graft versus host disease. So you must irradiate the blood product to prevent this form of, disease, the graft versus host. Why? Because if you do this, will you have any lymphocyte, alive lymphocyte? The answer is not. So if you don't have a live lymphocyte, done. You don't have a problem. Yeah? And yeah, that's pretty much it for the graft versus host disease. Okay, so remember, in the graft versus host, you have systemic symptoms. Diarrhea, maculopapular rash, jaundice, all of these are systemic symptoms. In the other one, they were mostly localized symptoms to the same organ. In the hyperacute, we had what? Thrombosis. Acute, vasculitis. Chronic, arteriosclerosis. Done. That's it. Smooth muscle proliferation, basically. Okay. So that's it for this page. Now, after the break, I'm going to speak with you guys about different types of immunosuppressant drugs, and then we'll finish it up with monoclonal antibodies. So see you guys after the break. We'll take just 10 minutes breaks. See you guys after the break. Welcome back, guys. So let's take a look. Now we are going to speak about these immunosuppressant. I will try to explain it in not the typical way. Basically, when we speak about an immunosuppressant, we are trying to destroy the immune system. So, why would we like to destroy immune system? Multiple causes. First one includes 1. Organ transplant. 2. Autoimmune diseases. Autoimmune diseases. 3. Inappropriate inflammation that requires to be stopped right now. Okay? So many multiple causes. So let's take a look. Starting with, first thing to explain is this graph. You're like, wait. You have a whole page you did not explain and you are jumping directly here? Yes. Because I will be explaining this first of all, then we'll go back here and it will all make sense. So let's take a look. Immunosuppressive targets. So we have a picture here, and this basically represents a lymphocyte. This is a T helper cell, okay? This whole picture is a big T helper cells. Guys, do you remember which interleukin activate the T cells? Which interleukin activates the T cells? Just a second. I was asking which interleukin activates the T cell. Is it still breaking? Does everybody hear me, guys? Please let me know. Can you hear me? Can you hear me? Can you hear me, guys? Okay, good. So we have here a picture of T helper cell. Can you tell me please which interleukin normally activates the T cells? Excellent, it was interleukin 2. Interleukin 2. So interleukin 2 normally activate the T helper cells. This is absolutely correct. If you forgot about this, just remember about the mnemonic, the hot T bone stick. So hot T bone stick. So hot T, it was hot T, interleukin 2, activate the T cells. So this will be super important now. So now we will speak about the process of the creation of the interleukin 2 and how it leads to activation of the T cells. So this is a T helper cells. Notice here, it has an interleukin 2 receptor. This interleukin 2 receptor can be activated by what? Interleukin 2. And this interleukin 2 can go inside of the cell, activate something called the mTOR. This mTOR can lead to proliferation of some genes that can lead to division of the T cells, okay? So that creates more T cells. If you speak about this area, you can see here the CD4 and the CD3 and the T cell receptor. These can activate something called the calcineurin. So this calcineurin converts something called NFAT phosphatase into NFAT. This NFAT can descend all the way until the genome of what? The T helper cells. And it can make inflammatory cytokines. I want you to make the most hugest note you can make and write near inflammatory cytokines, interleukin 2. So now this process of formation of NFAT has helped the genome of your T helper cells to make interleukin 2. Now this interleukin 2, where it will go? Outside of the cell, okay? So it will go outside of the cell and it will lead to binding to the interleukin 2 receptors, which activate the mTOR and lead to proliferation of genes, okay? So far so good. Now the next step is as follows. We have this process until here, it all makes sense. We had to make interleukin 2. How to make the interleukin 2? We converted the NFAT-B to NFAT using calcineurin, and this calcineurin was stimulated by the T cell receptor. Yeah? This NFAT then went down to the genome of the T helper cells, led to the formation of interleukin. This interleukin 2 came out and bound on the same cell, which led to basically auto-stimulation. It stimulated itself, yeah? Auto-stimulation. That stimulation led to formation of mTOR, which led to proliferation of genes and formation of more nucleic material that will be used in what? In formation of new cells, new T helper cells, which is what we want. Okay, good. So this is general idea. The drugs, will speak about them in a moment. So in this area, this is a bit different. In this area, it's not related to the interleukin 2. Well, if you need to do proliferation of the gene and you need to make more genes, what are genes made out of, guys? What are genes made out of? Our genes are made out of what? Not amino acid. Amino acid makes proteins. Nucleotides. Yes, nucleotides. Excellent. So our genes are made out of nucleotides. And the nucleotide, if you remember, I explained in the page, I only explained a couple of pages of biochem. And on these pages, on the second page, if you remember, we spoke about the nucleotides. And can someone tell me what a nucleotide have in their structure? They do have sugar. That was a nucleoside has no sugar. No, sorry, both of them have sugar. A nucleoside has no phosphate. They have sugar, but it's a deoxyribose. Okay? So excellent. They have the phosphate, sugar, and nitrogenous base. 3 stuff. So to form that DNA, we needed 3 stuff: ribose, sugar, and ribose, and basically the sugar, the hydrogenous base, and the phosphate. So moving on. You can see here that we have something called Brbb aminotransferase and IMB dehydrogenase. Both of these lead to purine nucleotide formation. Purines, remember, pure as gold. As is as what? Which one? Adenine. Gold is guanine. Pure as gold. Adenine and guanines are form of purines. So that lead to de novo purine synthesis. And the purines are a form of what? Nucleotide. Yes? Which we need for what? For formation and the proliferation of our gene. So if you inhibit the formation of our genes by inhibiting any of these enzymes, you will have less purine, less DNA replication, less amount of T helper cells. If you decrease the calcineurin, you will have less NFAT, less cytokines formation, less activation of interleukin 2 receptor, less mTOR, less proliferation gene, less T helper cells. So that's the whole idea about the immunosuppressant. It's something that inhibits your T cells. So let's speak about how this process actually occurs. Exactly, I mean. So the general idea, I hope you got. We are making these cells dysfunctional by preventing them from doing their function, which is exerting an immune response. So immunosuppressants are agents that block lymphocyte activation and proliferation. Okay? So they reduce acute transplant rejection by suppressing cellular immunity, used as a prophylaxis. So we use this immunosuppressant as a prophylaxis to prevent rejection. Let me ask you this, guys. In acute transplant rejection, will it be less than 6 months or more than 6 months? The rejection, I mean. Less than 6 months. Excellent. And frequently combined to achieve greater efficacy with decreased toxicity. Guys, these drugs are basically toxins. So if you give too much of them, you can kill the patient. So we would like to use different drugs that have different mechanism of action to get a synergistic power and in the same time get less toxicity. Let me explain what does the word synergism mean. Well, if we have 1 plus 1, how much is 1 plus 1? It's 2, yes? So if we use a drug that has the power of 1 plus a drug that has the power of 1, it will be 2. We call that potentiation, okay, of a drug. Explain this more deeply in pharm, but now just a general idea. Now there's something called synergism, in which if you give a drug 1 plus a drug 2, the first one is 1 strong, plus 2 plus 1 has 100% strength. The total of them will be more than any of them alone. So the answer will be 3. 1 plus 1 is equal to 3. So the strength of combining these two together will be much higher than giving a double dose of one of them. Yeah? So chronic suppression increases the risk of infection and malignancy. Obviously, you destroy the immune system, so you will not be able to defend your body against malignancy and infection. Starting with Cyclosporine and Tacrolimus. So for cyclosporine, it's a calcineurin inhibitor that binds to something called cyclophilin. You must know about cyclophilin. After binding to the cyclophilin, they block the T cell activation by the prevention of interleukin 2 transcription. Let's take a look, shall we? So this is a calcineurin, yes? So we said about cyclosporine inhibiting the calcineurin. How it did this? Well, basically, cyclosporine bounded to something called cyclophilin. Cyclo with a cyclo. Keep cycling. Each bicycle has 2 cycles. Yeah? So you keep cycling on this one and inhibit calcineurin. So you will not be able to dephosphorylate the NFAT. So you will have more NFAT-B, less NFAT. If you have less NFAT, you will have less transcription of interleukin 2. Less interleukin 2. So less inflammatory cytokine genes. Okay? Good. So less inflammatory cytokine genes, for example, what? Interleukin 2. If you have less interleukin 2, you will have less interleukin 2 receptor activation, less mTOR, less proliferation of the gene. I hope it's fitting. So let's take a look. Again, calcineurin inhibitor binds cyclophilin, block the T cell activation by preventing interleukin 2 transcription. So we use it for psoriasis and rheumatoid arthritis to decrease the effect of this autoimmune disease. You need to be really careful because these guys do have really horrible side effects, including nephrotoxicity, hypertension, hyperlipidemia, neurotoxicity. They basically are toxin. They destroy everything. Couple of side effects you need to know about: gingival hyperplasia and hirsutism. These are the most important. So let's take a look at gingival hyperplasia. Gingival hyperplasia. And until I find it, can someone please write me Which other drug lead to gingival hyperplasia that we already studied? Which other drug lead to gingival hyperplasia? Well, one drug was no. We had calcium channel. Yes. Calcium channel blockers and phenotine. Yeah, phenotine. So these two drugs can lead to gingival hyperplasia. This is 3 drugs actually now. So this is actually the only 3 drugs in the whole book that you have to know about leading to gingival hyperplasia. That's it. Any other drug is not required from you. So let's take a look. Yeah, what about hirsutism? They will have a lot of hair. Guys, there is a difference between hirsutism and virilism. I'll explain it now. So this is hirsutism. What about virilism? Well, let me explain the virilism and the difference between the two. Well, let's speak about can a lady have a little bit of hair on her mustache? A lady, a little bit of hair, not much. Yes, she can. So if she has a lot of it, we call that hirsutism, not virilism, because normally she can have a little bit of hair on her mustache. Can a lady normally have hair on her chest? It's less likely. It's possible, but less likely, okay? So basically, can a lady have hair on the body, let me show you the trunk. Not this trunk. Basically on this area. Can she have hair on this area? Even men don't have hair on this area. Yeah, they cannot. If a lady have hair on an area that normally hair does not grow at, we call it virilism. But if she has hair on area of the body that hair normally grows at, we call it hirsutism. Okay? So if it is on an area of the body that hair normally grows at, we call it hirsutism. But if it's an area that hair normally does not grow at, we call it virilism. Okay? So virilism. Maybe you know, guys, warfarin. Sorry, not warfarin. Warfarin. I mean, like this guy, like who looks like a wolf, basically. Yep. In case of virilism, it's kind of bad. Like they have ridiculous amount of hair everywhere, and it's a hormonal dysfunction and it's super serious. But mostly it's treatable, I have to say. Speaking about tacrolimus is also called the NK506 binder. It's a calcineurin inhibitor still, but it does not bind to cyclophilin. It binds to something called FK506, also named FK-Brbb. So FK-BB. So, okay, it blocks T cells activation by preventing interleukin-2 transcription. Let's take a look how it does that. Well, here is tacrolimus. It binds to the NK-BB, which lead to inhibition of calcineurin. No calcineurin, no NFAT, no inflammatory cytokines, no interleukin-2, no activation of the interleukin-2 receptor, no activation of interleukin-2 receptor, no mTOR, no proliferation of the gene. Done. Next. So tacrolimus, we spoke about the mechanism. We use it as an immunosuppression after solid organ transplant. The side effects are the same, but it does not have the gingival hyperplasia or the hirsutism. However, it have really high risk of diabetes and neurotoxicity like the other one, like the cyclosporine. So both of these guys actually do lead to nephrotoxicity. So both of the calcium urine inhibitor are highly nephrotoxic, especially in high dosage in patients with decreased renal function. Let me give you a new word. You will see a question telling you guys about basically, like, they will speak about histological finding of someone who had like chemotherapy with the basically calcium urine inhibitor, okay? And they will be telling you, oh, what you will see in histology, okay? So if you get that question, search for the answer that says vacuolation. If you have an answer saying vacuolation within the tubules, that's your correct answer. Basically, if you look at the tubule, it should be symmetrical. But if it has like a side hole, that's characteristic. Yes, I can. Just a second. So if you can see here, I hope you can see that there is a vacuolation, little vacuole formation on the side of the tubules. So in your word, you would get a question telling you about, oh, you have a patient who was started on a chemotherapy. After the chemotherapy, his creatinine level started to go up. And then they will show you this picture. You will take a look at this picture and you will see this vacuolation process is happening here. And inside of the tubules themselves, you can see empty spaces. So what is that? That's basically a side effect of what? Of the cyclosporine, okay? And other drugs. Good? So basically, just a side effect of chemotherapy is vacuolation of the tubules. Vacuolation of the tubules is a side effect of chemotherapy. Yep. Okay. So the next one is Ceralymus. So remember about the Cerbacillus, which is Ceralymus and basiliximab. So the Ceralymus, rapamycin, it's an mTOR inhibitor that binds to the NKBB. Where did we hear that? In Tacrolimus. NKBB, but the target is different here. Okay? It blocks T cell activation and B cell differentiation by preventing the response of interleukin 2. So, this is important. Guys, when we spoke about tacrolimus and cyclosporine, both of them reduce the production of interleukin 2. How? By decreasing the transcription of interleukin 2. But now we are going to speak about the mTOR inhibitor, the rapamycin on the Ceralymus. So when you inhibit the mTOR, you are not preventing the production, you are preventing the response, okay? The response of interleukin 2. Remember, the interleukin 2 normally bound here. So now you have poor response. Yeah? So in case of Ceralymus, you have a poor response to the interleukin 2, which lead to less gene proliferation. Let's take a look. So mTOR inhibitor bind NKBB, blocks the T cell activation and B cell differentiation by preventing the response of interleukin 2, basically because all of your T cells become dysfunctional. We use it for kidney transplant rejection prophylaxis, especially in Cerbacillus kidney transplant. Okay, so it's for kidney transplant. So the basiliximab, anything that ends with a mab is a monoclonal antibodies, guys. This one is against the interleukin 2 receptor. So if you take a look here, we have diclizumab and basilizumab. They bind to the interleukin 2 receptor, preventing the response of interleukin 2, not the transcription of interleukin 2. Which drug prevented the transcription of interleukin 2? That was tacrolimus and cyclosporine. Okay? Now let's take a look back to this thing. So pancytopenia in Ceralymus, insulin resistance and hyperlipidemia. However, it's not nephrotoxic. It's easy to remember this because we use it in kidney transplant. Oppa, can you hear me, guys? Okay, so we use it for kidney transplant. Why? Because it's not nephrotoxic. Well, basiliximab is a monoclonal antibody that can lead to edema, hypertension, and tremor. They like to ask only about the hypertension. In this drug, the mechanism is unknown. So, kidney survivors. Is synergistic with cyclosporine, also used in the drug-eluting stent. You're like, drug-eluting stent? What is that? Well, drug-eluting stents are some form of a stent that you will learn about in step 2, and they are crazy about them in step 2, and I understand why, because they are super important. So, the drug-eluting stent is some form of a stent that we use it for coronary arteries to dilate. So, you basically enlarge this stent, and it has high immunosuppression. So I have a question for you guys. So these stents have a lot of immunosuppressant drug on them, the Ceralymus. So can an acute inflammation happen there or not? It's impossible, exactly. It's impossible to have acute inflammation. If you will not have an acute inflammation there, guys, no acute inflammation. Think about it. If you do not have an acute inflammation at that area, will it occlude? It will not. It will be really difficult for it to occlude, to close. And that's the idea about the drug-eluting stent. It's really difficult for them to occlude. While, on the other hand, there is there is metal stent, and these metal stents have really high risk of occluding really quick. You know, we have the bare metal stent. The bare metal stent can occlude quite quick. The other one, the bare metal stent, they still have some goods, you know. But yeah, we will see the good and the bad for them later. So you can see here we have two forms, the bare metal and the drug-eluting. For the step 1, you should not know about these. For the step 2, they are crazy about it. So, if we speak about the azathioprine, mucophenolate mofetil, you will notice that now we are done speaking about the interleukin-1 pathway. We spoke about Tacrolimus, we spoke about cyclosporine, we spoke about the Ceralymus, we spoke about the interleukin-2 receptor inhibitor. Now is the time to speak about the drugs that inhibit the purine nucleotide synthesis, which decrease the replication of DNA, which decrease the proliferation of the gene by decreasing the substrate of that gene. So azathioprine, it's an antimetabolite precursor of 6-mercaptopurine. It inhibits lymphocyte proliferation by blocking the nucleotide synthesis. So let's take a look what they mean. So azathioprine gets converted to something called 6-mercaptopurine. This 6-mercaptopurine inhibits an enzyme called Brbb, aminotransferase. You are like, where did we see that before? I will show you. Maybe you saw it. I did not explain that yet, so it's okay for you not to know it now. It's basically here, guys. The 6-mercaptopurine or the azithromycin work at this pathway, okay? Which is what? The purine production pathway, okay? So you can see the mucophenolate also work here. And these drugs, by working here, they inhibit the de novo purine synthesis. They inhibit the production of a purine. If you have no purine, you have no adenine, you have no guanine, you have no nucleotide. If you have no nucleotide, you have no DNA. If you have no DNA, you don't have enough DNA to make what? Division of your T helper cells. No division of the T helper cells, you have immunosuppressant state. Okay. So, they write, it's used for rheumatoid arthritis, Crohn's disease, glomerulonephritis, and other autoimmune condition. Obviously, guys, this is not a specific of this drug. They are immunosuppressant. They must lead to myelosuppression. All of these drugs lead to the same thing. Notice, pancytopenia, 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 and the steroids is the only rare thing. We'll speak about later why. But in general, these drugs as an antimetabolite that kills your DNA, they must lead to pancytopenia. And it's actually a good thing. It means that the drug is working. 6-mercaptopurine degrade by xanthine oxidase. So you must be really careful. What is an xanthine oxidase inhibitor? Which drug inhibits xanthine oxidase except allopurinol? Well, we have allopurinol and we have a drug called febuxostat. Okay? These two drugs are xanthine oxidase inhibitor. Yep, forgot. Allopurinol and the other one was febuxostat. We'll explain it later. We still did not do that. But be careful when using that drug because you will have accumulation of 6-mercaptopurine, which can lead to toxicity and pancytopenia. So mucophenolate, mofetil. It reversibly inhibits IMB dehydrogenase, which prevent the purine synthesis. So when you have no purine synthesis, you will have no B cells and T cells. It's a steroid-sparing agent in rheumatic disease. Some patients who use steroid for a really long time start to develop Cushing-like symptoms. So you would like to taper them off basically and stop the what? Stop the steroid. You need to convert them on another drug. It could be mucophenolate. So they can have from the mucophenolate GI upset, again pancytopenia, hypertension, hyperglycemia, and it's less nephro and neurotoxic. It's associated with CMV infection, the M for the M. Finally, let's take a look here first of all. Mucophenolate inhibit IMB dehydrogenase, no purine nucleotide, no DNA replication. The last thing before the break will be regarding the steroids. They inhibit the NF-kappa B, which suppress both B and T cell function by decreasing transcription of the interleukin 2 and induction of T cell apoptosis. So, steroid lead to interleukin 2 apoptosis, also inhibit NF-kappa B, which decrease the production of interleukin 2. Yep. So here we have many autoimmune and inflammatory disorder. So we have inflammatory disorder, adrenal insufficiency in addition, also asthma and CLL. Now I will ask you a few questions. First of all, why the hell would the steroid lead to adrenal insufficiency? Because where do we normally have production of our glycocorticosteroid, guys, in our body? Cortex of the adrenal, correct. So if the adrenal is already like, if you are giving something from the outside, if you are bringing delivery to home every single day, your wife will not cook. Just it's a common sense, yeah? If you are giving glycocorticosteroid from the outside, your adrenal won't work. So if you already have adrenal insufficiency, because of that, you must continue the steroid. But what is other cause? Yep, exactly. But what is other cause that is super important for adrenal insufficiency? What is another cause of adrenal insufficiency except the exogenous supply? Starts with a W. Wilson disease. Okay. So Wilson disease can be one. Also, it could be like autoimmune adrenalitis, which is inflammation of the adrenal gland, and tuberculosis. Okay? Okay, So asthma as well can be an glycocorticosteroid, and also because of the edema basically, and CLL as well. Okay. Also, we have non-Hodgkin's lymphoma. We can use it for that as well because of the immunosuppressive state. Basically cures any leukemia or lymphoma. So side effects include Cushing syndrome. This is important. We'll speak about it again when we discuss endocrinology. But in general, these patients have the following. So they do have red striae on their skin, thin skin, moon faces, the buffalo hump on their back, and what else? Yep. They bruise easily, and yep, they have this thing. Good, good, good. Great. So we have the following: Cushing syndrome, osteoporosis, hyperglycemia. Why? Because steroids activate glyconeogenesis. Diabetes. Why? Because steroid activate glyconeogenesis. Amenorrhea, they basically lead to disturbance of the other steroid hormone. Which steroid hormone do you know, guys? Which steroid hormone are produced in the body that you know about? Mineralocorticosteroid, glycocorticosteroid, 6 hormones. Yeah, 6 hormones as well. So the 6 hormones are going to be decreased. Adrenocortical atrophy, because of the reason I told you about, which is basically if you bring something from the outside, your wife will stop cooking. If you bring glycocorticoid from the outside, your adrenal gland will stop producing. Peptic ulcer. Why peptic ulcer? Peptic ulcer is actually important. Steroids do not only work in the mechanism you just saw, guys. It also works in one more thing, which is called phospholipase A2. So phospholipase A2 has some relationship to, here it is. Okay, perfecto. Let me send you this picture. If you take a look at this picture, you can see the steroid inhibiting the phospholipase A2. I want a type A student to tell me in which disease did we have phospholipase A2 deficiency or a mutation. It's really difficult to remember. If you want a hint, it was in renal. It was in renal system, phospholipase A2 deficiency or a mutation. Come on. No, it was not polycystic kidney disease. It was not Albert, no. Not Albert, no. Come on, try. Well, let me give you a little bit, one more push. It was a nephritic or nephrotic syndrome, one of them. Come on. Counting to 5. 1, 2, 3, 4. And five. Okay, guys. Basically, the phospholipase A2 will be destroyed in this case. Membranous nephropathy. Okay? You must know about that. Good. So it's something from between the lines. I know it's not that high yield, but the moment that you have, like, you memorize this whole book and get really comfortable with it, guys, for step 1, I use this book. For step 2, I use this book. I'm currently preparing for step 3. I'm using still this book. So you need to know this book is not going to stay with you only for step 1. First aid for step 2 is useless. For step 3, it has no other blades except the garbage. This book is all what you need for all of the exams for the USMLE. So you need to master it. So, moving back here, we have the steroids. We spoke about them. And the picture I sent you guys was important for one thing. As you can see, inhibition of the phospholipase A2 will lead to less arachidonic acid. If you have less arachidonic acid, you will have less prostaglandins. And what protects your kidney? You guessed it, prostaglandins. No protection of the kidney, you get what? Where are they? Peptic ulcers. Psychosis as well is serious. It crosses the CNS. It can lead to psychosis. Please write a note next to psychosis. They are visual psychosis, not auditory psychosis. Next, cataract on their eyes, especially like, please know that the cataract, it's the lens, the organ that gets the cataract. So let's take a look at it quickly at the cataract. So it's the lens, obviously, the thing with the cataract, yeah? Okay. And a vascular necrosis, which is the femoral head. So the next thing, we have demargination of the white blood cells can lead to artificial leukocytosis. What do I mean? Well, basically, in this case, the neutrophils are unable to pass to the interstitium. If they cannot pass to the interstitium, you will have a fake leukocytosis inside of the vessel, yeah? Adrenal insufficiency may develop if the drug is stopped abruptly or after chronic use. Never stop such a drug abruptly. You need to taper it off because otherwise you can lead to this sudden adrenal insufficiency, which can lead to the patient getting shocked and dies immediately. Okay, and speaking about this, now it's just all piece of cake. Tacrolimus, cyclosporine, both of them inhibit the calcineurin. So you will have less NFAT. Less NFAT will lead to less formation of interleukin 2. Less interleukin 2 will have less activation of interleukin 2 receptor. The same thing when these two drugs work on the interleukin 2 receptor by blocking it. That will lead to less mTOR, which is also blocked by Ceralymus, also called rapamycin, which lead to less proliferating of the cells. Also, the azathioprine and the mucophenolate, each working by inhibiting an enzyme, lead to purine nucleotide to be reduced, which lead to less DNA replication, which lead to less T and B cells. I hope you understood, guys, the immunosuppressant. For now, let's take 10 minutes break and come back after the break to finish this class up. See you guys in 10 minutes. Welcome back, everybody. So let's take a look at what we have left of the immunology part. To start with, we have to speak about some hormonal stuff. I believe now we'll speak about the erythropoietin. Just a second. Let's take a look. Yep. So, recombinant cytokines and the clinical uses. So we have the bone marrow stimulation particle, including erythropoietin. Can someone tell me where we have reduction of erythropoietin normally happening? Okay, it's in the kidney, correct? So remember, in the interstitium of the peritubular capillaries. Yeah, we have this EPO analog production and we have the following anemias. So we can use this drug, which is basically aboitine alpha, is a form of erythropoietin, but it's recombinant. What does it mean, recombinant? It means that we make it in the laboratory. So we can use it in anemias. Which anemia lack erythropoietin? The one secondary to renal failure. Yes? It's associated with increased risk of hypertension and thromboembolic event. Why? Because thrombopoietin can increase what? It can increase your RBCs. What will happen to the viscosity of the blood if you increase the RBCs? The viscosity, it increases, which can predispose you to getting hypertension and thromboembolic events. Okay, yep, exactly. So colony stimulating factors include filgrastim and sarigramostim. So just look at the G and the G and the M. So if it has a G, it's basically what? It can lead to granulocyte increase in count. So what are granulocytes? Granulocytes are neutrophils, eosinophils, and basophils, all three of them, okay? So leukopenia, recovery of granulocyte and monocyte counts, okay? So remember, the granulocyte we use with filgrastim, and monocyte counts we use it for this guy. Well, basically this guy, he recovered both the granulocyte and monocyte count. So remember, when we speak about the monocyte and the macrophage, can someone tell me what is the difference between a monocyte and the macrophage? Monocyte and the macrophage. Exactly, a monocyte is inside of the vessel. A macrophage is inside of the interstitial. Perfect. So we have now thrombopoietin. We have romiplostim, which is a TBO analog, and we have also something called allothrombobag. So I just remember a thrombocyte bag. You know, thrombocytes are the same as platelets. So we can use it in case of autoimmune thrombocytopenia because it's a platelet stimulator. It increases your platelet. To be fair with you guys, everything I'm going to speak about now, just like general stuff, you know, it's solely memorization. Toll-like receptors, number 7, this drug, imiquimod, can be used as a chemotherapeutic agent, but it's used as a cream, okay? It's used as a cream to treat anogenital warts. Anogenital warts. Can somebody tell me, please, anogenital warts are due to what? What causes anogenital warts? HPV virus, exactly, HPV virus, yep. Okay, so it could be due to HPV virus, and we use this drug topically on it, and you just like mass it on it and it disappear after sometimes, okay? So, but it's not a cure. Why? Because it can reoccur. It can reoccur, sadly, okay? Yeah, so you can use this drug, they will disappear, but they might come back. They might come back just for the clearance sake. And also for actinic keratosis. So what is actinic keratosis? Actinic keratosis is a precancerous lesion. Basically, this lesion happens before you get a squamous cell carcinoma. Yeah? So this is the before and after for the, you are asking about actinic keratosis. So let me tell you, this is actinic keratosis. It's a precancerous lesion, and when it becomes cancer, it would become squamous cell carcinoma. Okay? So, yep. So this is actinic keratosis. It like mostly to affect the face, guys. It like to affect the face. Why? Because it's mostly exposed to the sun. It's a crusted lesion. Look, it looks crusty. Yeah? Guys, what is this? Oh, actually, this is cool. If you get a question about this guy, What does he have? What is this? And is it real? Horn? It's not horn. It is, first of all, yes, it's real. But this is squamous cell carcinoma, a form of squamous cell carcinoma that grows excessively. Okay? So, yeah, it's kind of interesting. Yep. And some person online just find something like that and be like, human horn, look, he's Satan. Well, no, he's not Satan. The poor man has squamous cell carcinoma. So, next, interleukin 2, it can activate the T cells, and if you have hyperactivation of the T cells, you can kill the cancer cells. So, L-dysleukin activate your interleukin 2, which can kill the renal cell carcinoma and metastatic melanoma. It's not perfect, but we still use it. The interferons alpha can be used for hepatitis C. It's not the preferred anymore. Why? Write a note, because we have better drugs for it. But it is still preferred for hepatitis B, however. For renal cell carcinoma, interferon alpha can be used as well, because it decreases the risk of metastasis, basically. Okay? Come on. No. The hell? Just a second. Yep. And if we speak about interferon beta, it can be used for multiple sclerosis. It decreases, actually it improves the prognosis significantly. Finally, interferon gamma can be used for chronic granulomatous disease. If you remember, it was the disease with the NADPH oxidase deficiency. Patient with a chronic granulomatous disease, guys, can somebody tell me, I will say 3 bacteria's name, and you will tell me which of them can have high risk of chronic granulomatous disease. Is it E. coli, Staph aureus, or Salmonella? It's Staph aureus. It's because it's the only one that is catalase positive. Okay, good. If you don't know that now, it's okay. We did not do microbiology, but when we do it, you must know that. Now, therapeutic antibodies. These antibodies are used for various diseases, and this is one of these pages that you will have to repeat like 20 times until you master it. So, speaking about therapeutic antibodies, we have antibodies that are used for autoimmune diseases and other antibodies that are used for other disease. Starting for the autoimmune disease, we have adalimumab and anifliximab. Yes, they are soluble TNF alphas, and they basically destroy the TNF alpha. So that's their target. They go bind to the TNF alpha and destroy. So, okay, you will not have TNF alpha. I have a question. Do you remember, if you do not have TNF alpha, which disease will be disseminated in your body? Because it was normally contained within a granuloma. This disease was here. It was contained with a granuloma. So when you use a TNF alpha inhibitor, it will be released. Exactly, Mycobacterium tuberculosis. When you use a TNF alpha inhibitor, it will not be enrolled inside anymore, and it will disseminate all over the body. Excellent job. So, clinical use include IBD, which is inflammatory bowel disease, but not only. Also rheumatoid arthritis, ankylosing spondylitis, and psoriasis. Why? Because basically, you are reducing the function of TNF alpha, which is basically an inflammatory cytokines. You must screen these patients for TB due to the risk of reactivation. Please make a note. You also need to screen these patients for hepatitis B. Yes, this is important. Etanercept. Etanercept is a decoy of TNF alpha receptor and not a monoclonal antibody. This is actually important. Etanercept. Or etanercept if you want. So basically, what is the idea? The idea that it functions differently. If we spoke about the interleukin, this infliximab and the dulimumab, as you can see, we are binding to what? What do we bind? We bind the TNF alpha. But in the etanercept or etanercept, whatever you want to call it, it binds to the receptor of the TNF alpha. Okay? So yeah, it functions differently. Binds to the receptor, not to the TNF itself. The little r next to the TNF stands for receptor. So, acolizuumab, it is a complement, a protein that binds to the C5, which we can use in case of paroxysmal nocturnal hemoglobinuria. If you remember, in that disease, I told you that we had an RBC. On the RBC, we had something called what? BIGA. Yeah? BIGA. This BIGA held something into it. Can someone tell me what BIGA had held into it, which used to protect the RBCs from the complement? What BIGA protein holds on it to protect the RBCs from hemolysis? Come on. It holds something called meryl and something called DAF. Yeah? The CD55 and the CD59. These two, meryl and DAF, are a complement inhibitor. So when your complement wanna come and attach and kill your cell, he cannot. Yes? If he cannot do that, you basically are protected against your own complement. But let's say that your BIGA is gone. You don't have BIGA anymore. Okay? So your DAF and meryl cannot bind to your RBCs anymore. So your complement will attack your RBC and destroy it. Okay? So absence of BIGA will lead to destruction of the RBCs. And how do we call this disease? We call it paroxysmal nocturnal hemoglobinuria. Okay? Also, we have a disease called, and they use complement protein C5. Can somebody tell me at which complement does the membrane attack complex start? Which complement make the membrane attack complex? C5 to C9, excellent. So the first one is C5, so that's what you inhibit, okay? The next thing is something called iguasilicumab, which is an interleukin 23, work for psoriasis. Guys, for psoriasis, I have noticed something. All of the psoriasis drug has a K in the name, and then like it's weird, but it's weird. They have K in the middle of the name. So take a look. Kumab, Siconumab, Ixekizumab, where is also a K, Kinumab. All of these are used for psoriasis. Anytime it's for psoriasis, there is a freaking K in the name. Okay? I don't know why, but it's there. So if that is helpful for you, do it. Because sadly, this is a lot of memorization and you must memorize it. And the names of them are just really confusing to memorize. I mean, seriously, without Anki, this is almost impossible to memorize. So the next thing is interleukin 17 alpha. And that also for psoriasis and the psoriatic arthritis. Next, we have the integrin for multiple sclerosis and the Crohn's disease. Inhibition of the integrin can lead to a disease called BML, which is due to activation of GC virus. So this is important. I will show you how it looks like. Yeah, you can see there is demyelination of the whole thing. Yeah, so we call that progressive multifocal leukoencephalopathy, which is due to reactivation of the GC virus in patients who are immunocompromised. So that's BML. I'm going to explain this topic again when I do nervous system, and when I do microbiology. It's super important. PML is due to the GC virus destroying the myelin by destroying the oligodendrocyte. Okay. Next, we have another kin, which is like psoriasis type of thing. We have also vedolizumab, which is for alpha-4 integrin, used for IBD. This is a new drug, got a specific anti-integrin preventing migration of a leukocyte to the gastrointestinal tract, which led to less destruction of your GI mucosa, and thus we can use it in inflammatory bowel disease, like a Crohn's disease, and not only, also ulcerative colitis. Other application of monoclonal antibodies are denosumab, which is used against the rank L. So how do they work on the rank L? Rank L is basically located at the osteoclast. And if your osteoclasts are not functional, you will not have destruction of your bone. Yes? Basically, it inhibits the osteoclast maturation. Remember, osteoclast destroy your bone. Osteoblast build your bone. Clast destroy. So you don't want it. You will inhibit it. And there is a normally occurring substance inside of the body that does exactly the same as denosumab, called osteoprotigrin. Okay? We'll speak about it more when we discuss the disease osteoporosis. But basically, these patients tend to have, with osteoporosis, a lot of activity of osteoclasts that need to be inhibited, which can be inhibited by denosumab because it decreases the osteoclast activation. Denosumab helps make dense bones. So the next one is emicizumab. Emicizumab is a factor 9 and 10. Of course, we are speaking about the clotting factor. And it can be used for hemophilia A. Bispecific mimics factor 8 as well. Guys, I have a question. Are these drugs cheap or expensive? Somebody says cheap, somebody says expensive. Somebody with a $3 sign. Okay, let's see the prices. And you will know why I'm checking for the prices in a second. Okay, so take a look. You will decide. Okay, so 1 year treatment with this drug is $448,000. That's a lot of money. If you don't have insurance, basically you are toot. So that's the thing. You need to keep in mind that exactly a lot of people have hemophilia, but we still don't use this drug except for those who are in a really bad state. So a lot of people actually do die because of lack of money. So you need to keep that in mind. When you have these medications, it doesn't mean that we can give it to anybody. You need to be realistic. Not everybody will get this treatment, sadly, because of insurance stuff. And you cannot do anything about that, as a doctor. But you can provide alternative therapies like giving actual clotting factor, which is not as helpful. This is much better than it. But still, it's better than nothing. The next drug is called omalizumab. It's an IgE. It destroys the IgE basically. It's for refractory allergic asthma. It prevents the IgE from binding to the Fc portion of the RI. Well, I want to show you this. This is actually kind of interesting. So here it is. Let me see. Okay, good. So the allergen can bind to the IgE. And this IgE will bind to the Fc portion with its Fc portion to this receptor on the antigen presenting cells. That antigen presenting cells later will lead to presentation of the cells to the mast cells, which will eventually lead to creation of histamine and other cytokines. If you give this monoclonal antibodies, you will prevent the IgE from binding to this guy, and here as well, it will not have binding of the IgE, which prevents both the degranulation and the internalization process, and thus help in case of asthma. Finally, bevacizumab, it's an RSV-F protein, which is located on the respiratory syncytial virus. It's a disease, respiratory syncytial virus. It's one virus that affects the baby and lead to one respiratory disease that we'll speak about it later. Anyway, these patients will be suffering, and if they are high risk, for example, they are immunosuppressed, they are premature, you can give it. Please make a note, you have to give it in less than 2 days. Because if it's more than 2 days, the drug is not effective, okay? So I mean, you need to give it within 2 days within starting of the symptoms, because after that, the drug is useless, okay? So that's bevacizumab. And that's it for the monoclonal antibody. I know that they are kind of like a lot of memorization, but that's it for them. And here we go, done with one more system. So we finished cardiology, renal, and immunology. We'll have one class to review all of immunology again. And yeah, keep that in mind. I think it will be on Monday. Tomorrow is off, as you know, guys. Okay, and pathology. Yeah, actually good idea. Immunology and pathology in the same day. Okay. Oh yeah, we finished pathology as well. We finished 4 systems, guys. We finished renal, we finished cardiology, we finished pathology, and we also finished immunology. About the question that I sent, I will not send you the explanation yet, and I will not explain it. I will explain it tomorrow for a good reason. I want you to think about it. This is a real exam question. It's one of these experimental questions that tend to be the hardest. We call them the 270 question, which is like the hardest form of the question that you can ever see on an exam. That's why I sent it to you guys. I want to see how hard you can think about it. I explained it already. So if you can listen back to my lecture, you can find it and you can answer it. So, by the way, all of these questions I explained during the lectures, but maybe sometimes you don't notice that I'm basically telling you the exam questions. So anyway, good luck everybody. And for the next system, according to the bowl, it's biochemistry. I'm going to reopen the bowl one more time today, just to make sure you guys want biochem. Because biochem is difficult. I cannot lie to you and tell you, oh, it's a piece of cake, it's easy. Biochem is difficult, but if we finish that, everything else is a piece of cake. So we have biochem next. And when we finish that, everything else is easy. We don't have any actual difficult system anymore. Okay. How much immunology on the exam? I believe around 10%, but I have to recheck that. It's actually a big amount. It has a good chunk on the exam. Okay. Step 1, USMLE score distribution. If I'm not mistaken, you can open your first aid in the initial pages, guys. In the initial pages, these pages that nobody opens, if you know, go back then and you can find a lot of stuff. I mean, for example, you can see according to your score which specialty you can match to. Yeah. You can also see the percentile of your score. Okay. Oh, nice. That's me. Here I am. So you can see also, yeah, there is plenty of stuff here. But according to the subject distribution of the score, here it is. Okay, so you ask about which one? Yeah, so it's not immunology alone. They include the hematology with it. So the immunology together with the hematology is 7 to 11%. Okay? So, but this is not completely true because it's all interrelated with each other. Thus, we don't like to use this because it's not real, you know? Because in fact, if you go to the real exam, you will see most of your exam is CNS and CVS. Like I'm speaking about 40% or 50% of the exam is just like about the heart and about the brain. So Anyway, guys, enough rambling. I will see you guys on Monday, and hopefully we'll finish up all of this thing. So see you guys later. Bye bye.